Morning, everybody. Thank you for joining us for our March meeting. We're pleased to have three guest presenters here this morning. And we'll get to our guests in just a minute, but I want to begin, as we always do, with sort of a little recap. First of all, talking about where we are in terms of numbers and what we've seen, keeping in mind, as we always do, that even one person losing their life to an overdose is too many. But what we have seen in this since our February meeting, which is really remarkable, is a 32% decline again in the number of fatal overdoses we have seen. So last year in that same time period, we had 41 overdoses. This year we had 28. Obviously, one being too many, but as we always talk about that, if you think of the circle of people that suffered that loss, and even if you conservatively say 10 people for every person lost, that's an incredible decrease. And that is really attributable to the work of the people on this call. This multidisciplinary approach that we've adopted here has really yielded results, and results in ways that people aren't seeing in other places. So I hope that you give yourself credit for the work that we are doing and the impact it is. And it's also reflected in the programs and the speakers that we have here, because many of those ideas come from things that other people hear about, or people are asking us questions, and then we find experts in those areas to come. You remember last month, we had 4 people with us. We had John Kelly from Pride Star Trinity, who talked about First Watch. And I'm happy to report that that got such attention that we've since had some legislative meetings about trying to fund that statewide. We also had Pauline Hogler, the certified professional dog trainer, who is the director of Golden Opportunities for Independence. And she talked about the use of dog training as a way for people to get themselves independent and also to get some financial stability. And then we had Professor Beletsky from Northeastern School of Law, who, and Alice will be putting these in the chat during the meeting, since he spoke with us last month, has been quoted in about 6 different articles dealing with substance disorder and some of the pieces that he talked about, the impact of criminal law and its effect on people struggling with substance use disorder. And we were also happy to welcome Joan Taglieri from Cambridge Health Alliance to talk about the new facility that they've just opened in Malden. So that issues of supports, we hope that one of the things that does, and I know a lot of people took advantage of the information that Joan had. That's a program that really has no waiting list right now. They have availability, and we want to spread that across the county, that information. You may have seen, and I think it dovetails with what Professor Beletsky talked to us about, but also all of this support information. A few weeks ago, the RAND Corporation in the American Journal of Public Health published a study that indicated that in the New England states, including Massachusetts, almost 1 in 2 people, population-wise, and think about our population just in Middlesex County at 1.8 million, almost 1 in 2 adults has a familial or friendship connection to someone who suffers a fatal overdose. Just think about that. That's an incredible statistic. It shows us the need that people have for support, and the fact that we don't necessarily know that or think in terms of that number shows us there still is some stigma that we need to be working to address. And it also shows us the continuing need for the work that we have been doing. And for Cole-a-Miss, that in many states in New England, including Massachusetts, it's almost a 1 out of 2 of people have a connection, a personal or friendship, familial or friendship connection to someone who suffered a fatal overdose. So just look at the number of people on this meeting. If you think that essentially 1 out of 2 of everybody here has that kind of connection, it reminds us that as well as we are doing and as much work as we have done, there certainly is so much more work to do. And also the importance of this task force. And I'm really happy today to have Dr. Avik Chatterjee back with us. Dr. Chatterjee joined us back now a little over 10 years ago when we first started these meetings up in Lowell. And we seated these meetings at Lowell General Hospital because we wanted to reinforce the fact that this was a public health issue. It was not just a criminal justice issue. And we wanted to address some of that stigma that people would feel about coming to a meeting at the courthouse or the police station. So we put it in the hospital. And Dr. Chatterjee was with us in the beginning, and I'm really happy to have him back here today. He is a med-peds trained primary care and addiction medicine physician at several of the shelter-based clinics through Boston Healthcare for the Homeless program. And his area of clinical work and research includes innovative treatment models for opioid use disorder in marginalized populations and intervention on those social determinants of health, such as food insecurity. He has an additional interest in racism and healthcare, particularly as it manifests itself in the medical education and training that we are giving to people who are going to be doing this work. You might have seen his editorial in the Globe last Wednesday, and if not, we'll put that in the chat as well, raising his concern about the legislative proposal to place time limits on families living in shelters. There's been a lot of talk about that this week, and how much that population would benefit if instead we were doing increased funding for emergency housing, talking about rent control and the Massachusetts voucher program, which can support families in crisis. And Dr. I thank you for raising those concerns we are seeing every day, particularly in some of our communities, as the issues of homelessness and housing instability just continue to grow, and particularly as it's impacting every part of that family. We're seeing an enormous amount on kids and their schooling and what's happening with them. But I'm going to turn it over to you now, and thank you again for being with us and having stayed with us all these years.
Thank you so much for the introduction and for the invitation to speak. And I appreciate you talking about the editorial. It's been really heartbreaking because, as many of you know, since 1983, when the commitment from the state that we would provide shelter to homeless families started, to my knowledge, this is the first time, and certainly the first time I've been taking care of families since, in the past 10 years, that I've contemplated having to send children and even infants, so as young as a year, back out to the street. Normally, if a family presents to us with kids, we can get them relatively quickly hooked up with DTA or one of our partner orgs. There's a place for them to stay. But for the first time, a couple of months ago, I had a patient come to me with an infant on the street, and there was nowhere to send them, and that, I think, is in violation of the state's moral and ethical commitments it's made in the past. And now they're talking about time limits on shelters on top of the caps. And so it's just very, very hard, as someone who works with, as DA Ryan just said, to then just have to send folks back on the street. That's not something we've done in Massachusetts before. So I think this is going to be a lot of chaos when they try to operationalize it. So we'll just see what happens. But I am going to talk actually today about overdose prevention strategies through the Healing Community Study. I actually it's really nice to look at the names on the Zoom here and see some names and faces that I recognize from our work together. So as DA Ryan mentioned, I work part-time at Boston Medical Center, and I was what's called community faculty on the Healing Community Study. And I was working in the first wave of the study on with Lowell and Northwest Middlesex County. And then in the second part of the study, I was working with Laura. So I haven't been back, but I was in person at one of the DA task force meetings back in, I think, even 2019 or maybe early 2020. So, okay, so I'm going to go through a few slides quickly, but I'm going to talk briefly about HCS, and then I'm going to talk about, the point of talking about HCS is to talk about ways we've tried to use HCS and in other ways to expand access to methadone, which is one of the 3 FDA-approved medications for opioid use disorder, and arguably is the most effective and one that is in the highest demand right now. because it is extremely effective at preventing fatal overdose in people with opioid use disorder. One of the studies out of Boston Medical Center, I think we've talked about this, showed as much as a 50% plus decrease in overdose death risk in people who had a non-fatal overdose before if they get onto methadone. So many of you, I think probably, if not all of you, know about the Healing Community Study, but it started back in April 2019. NIH and SAMHSA funded Massachusetts, New York, Ohio, and Kentucky to work with 67 highly affected rural and urban communities. You can see the communities in Massachusetts on this map. 16 communities were randomized either into Wave 1. Wave 1 was Lowell and Northwest Middlesex County. And then Wave 2 were other communities, including nearby Lawrence here. Okay, and then what is the goal of the Healing Community Study? Was to reduce overdose deaths through implementation of evidence-based practices, including OEND, so primarily Narcan distribution and education, then MOUD, so strategies to improve access to buprenorphine and methadone, and then safer prescribing. The main thing with HCS was community engagement, communications, and then the continuum of care, that is reinforcing all the points at which someone might engage in treatment or ways in which we could engage them to prevent overdose and overdose death. What made HCS different than other intervention studies, because it is over now, it was designed to be implemented in partnership with local communities. There was co-learning and capacity building. Some of you may have even been on some of the learning collaboratives where we basically had experts from communities in different types of interventions and strategies and populations teach each other and us, honestly, from BMC about what they were doing. And then the goal was to be a model for other communities trying to undertake this work. Yes, go through these. So out of BMC, there was a lot of expertise as far as a lot of folks that you can reach out to, including people like myself, training and technical assistance, communications campaigns, and then the funding. And yes, so we'll go through that. Okay, and then these are some of the communications campaign products, which I'm curious if any of you all saw in your communities. But as you can see from some of these images, these included images of people from the community itself. I think the lower right one is from Shirley Townsend, but people from the communities themselves were featured in the communications materials. And now what I'm going to talk about is the strategies that the different communities chose to increase access to MOUD. And I'll go through these, and then hopefully we'll have some time for questions. But one set of interventions that, so in Shirley Townsend, which was in contrast to Lowell, is very unique, right? Because it's a much more geographically spread out area. Unlike and in Lowell with Lowell General, there's not one big hospital or health system or clinic where it's obvious, right, that everyone would go, or obvious where we would need to expand MOUD access. But there were some really cool things that they did in Shirley Townsend. Through Emerson Hospital, we built out a community-based MOUD clinic. So this is a place where a patient could go and start onto Suboxone or even Sublocade injections, which are actually one of the most prominent things that they were doing. That was a really effective intervention for getting people in that area in a place that otherwise is sort of an MOUD desert to get started onto useful medications. There was also work at Emerson Hospital itself to increase linkages from the hospital to that clinic, and at the clinic itself, at the hospital itself, to start people on MOUD. One of the saddest things that we experienced, I would say, and one of the kind of limitations of a funded study like this, of a grant-funded study like this, is that I don't know how many of y'all know or have worked with Dr. Stephanie Strategos, but she was really a leader in improving access. She's the one who led the increasing bridge scripts at Emerson Hospital, then at the Groton Clinic itself. She was the provider there. She had to preside over basically the hospital and the clinic space there, saying, we don't want this anymore, we're going to shut it down. So after the grant funding stopped, I think the clinic lasted for about a year, and then basically there was opposition to this idea of treating people with addiction there, and the clinic was closed. It's really interesting because she tells a really good story about this and has sort of all these emails, but basically she was able to demonstrate that the clinic was actually making money, because a lot of actually she had reached out to BMC to provide some support around how to bill for the services she was doing. But the hospital would come back and sort of allude to the fact that it wasn't making money, even though she could prove it was, and they used that as an excuse to close it. But it was also clear that there's a lot of stigma around treating addiction in that setting, which is really frustrating. But better news, I think, in a place like Lowell. So I'll talk about a couple of the strategies to improve. And some of you all may have interacted with the Lowell Addiction Consult Service or the Lowell Bridge Clinic, which we'll talk about. But we supported a nurse practitioner to do addiction consult services at the hospital. What's cool about that is that the idea is that, so someone, let's say they come in with a urinary tract infection or a cellulitis or any number of things that, let's say, aren't even addiction related, but the doctor who's taking care of the patient realizes that that person actually needs methadone or buprenorphine for their withdrawal, or while they're there for their infection or whatever else, they want to start treatment. In the past, this has been a reason that people leave the hospital, right? So they're in the middle of their antibiotics, but they're like, I am in withdrawal for my methadone. And a lot of general doctors are not comfortable, even though it's completely legal and allowed and part of our purview, prescribing medications for withdrawal or treatment while they're there. So the addiction consult service is basically, in the case of Lowell, an addictions trained up expert to go around to the different patients and doctors and say, look, if this person is with withdrawal from alcohol, you can prescribe this, or if they're in withdrawal from fentanyl, you can prescribe this. We can get them started on methadone and go from there. This was hugely successful. And what was really, really cool was getting the stories from the doctors at the hospital. So Wendy Mitchell, who was the medical director there, she would talk about all of these patients who used to leave what's called against medical advice or on their own because they wanted to use, were all of a sudden staying to complete their courses of antibiotics for endocarditis or infections because they no longer felt like they were in withdrawal, or frankly, like they weren't being heard. And so beefing that up and having that continue after we left was a real success for us. And then the second thing I think was they had a fledgling bridge clinic prior, but HCS helped again beef up the funding, continue the funding for the staffing, and then actually now it's continued since then. But basically, the bridge clinic was for people in the emergency department, people coming in off the street, people whose primary care doctors didn't prescribe buprenorphine. There was a wait list, let's say, for methadone. They could come in and right away start onto medications. And this clinic was doing very, very innovative things and very caring and compassionate things to get onto people onto treatment right away. They were doing things like bridging people from fentanyl right onto buprenorphine through something called microdosing. All these very innovative things out of this program, this bridge clinic that's still going on to this day. It was a real pleasure working with them as they work through this stuff. And so I think Lowell and Northwest Middlesex County did a lot of really good stuff. And what was cool in the wave two, which was then later, obviously, was to look at what Lawrence wanted to do. So some of you may be familiar with the Greater Lawrence Family Health Center. And one of the reasons I bring these strategies up is because they might be models for Lowell or other communities in Middlesex County. But basically, they partnered really closely. And as much as we tried, we had a lot of trouble engaging with the opioid treatment program or the methadone program in Lowell. But in Lawrence, we had a very strong relationship, and a big partner in the coalition was the methadone program. So we were able to work with them in combination with Greater Lawrence Family Health Center. We had one of their providers. We paid for some of their time at the OTP in Lowell. And what that allowed them to do was to start anyone who came in the same day onto methadone. For those of you who work at all with methadone programs know that this is a relatively new thing, that you could walk into a methadone program and be started the same day as opposed to be put on a wait list or having to come back later. So that, I think, was a very innovative and cool thing, and would be a cool thing to have in place for any methadone program in Massachusetts. The second thing that is the I think one of the really cool things is we actually paid, and actually the community came up with, and then we supported a clinician, an intake clinician for methadone. Again, for those of you who work with methadone programs know, it's a very long intake program, but they put a methadone intake person on their mobile unit. So again, instead of people having to come to the methadone program to start, they could show up to this Greater Lawrence mobile unit and be started either on buprenorphine by the Greater Lawrence Family Health Center provider, or they could talk to the clinician and do the intake for methadone and then be walked over to the methadone program that same day. So that was a really cool, I think, additional way of moving outreach for the methadone program outside of the building itself and being in the community and getting people in, again, same day starts. The other cool thing about that is that what they embraced in the last half of the study is trying to start methadone at Greater Lawrence Family Health Center itself. So that would be like people going to Lowell Community Health Center, let's say in withdrawal, wanting to start treatment, and then being started on methadone right away. This would be the first community health center in the country that would be doing this. So Boston Medical Center does this out of something called the Faster Paths Clinic, which some of you may have heard of, where you start methadone right away based on something called the 72-hour rule, which is a carve out for the methadone restrictions that says that hospitals can start people on methadone for up to 72 hours until they can be accepted at an OTP. And BMC lawyers, basically looking at the law, reading through it, said that actually we can start this in our outpatient clinics as well. The Greater Lawrence lawyers looked at the law and said that this is something that we could do as well. And so currently they're trying to get that program off the ground, where basically you could go to a Greater Lawrence Family Health Center clinic, get started dosing methadone for 3 days, and then the OTP in Lawrence would take that patient over and start dosing them. So again, just a way to expand access to what we know as a life-saving medication. So I know that was a lot, but I wanted to talk about the great work that has been done in Middlesex County, talk about what the really cool things that Lawrence has done through HCS. The study ended in December, so all the work that's continuing is sort of on their own efforts now. But the fact that they're doing things that are, to our knowledge, groundbreaking at the national level as well to expand access to methadone. But I'll stop sharing now and happy to answer any questions that folks have. I see there are a couple chats, so I just want to make sure I'm not missing those. Anything? Great. Okay.
Yeah, people can either put questions in the chat or raise your physical hand or your electronic hand, whichever is easier for people. Yeah, Alice.
Doctor, could you go over again the carve out to the 72-hour rule, and if all that comes together, what they'll be able to do in Lawrence? You broke it down to a couple different steps.
Yeah. So right now, according to federal law, a place like Greater Lawrence Family Health Center or Lowell Community Health Center couldn't just dose people on methadone. In the ideal world, yes, like people could go there instead of, because the reason is, so Greater Lawrence Family Health Center has something like 8 buildings, all spread out throughout the city. There's one OTP in Lawrence, right? So I'm sure this is similar in your communities as well. The idea, it's at least in my experience, it's really not a good model to have everyone have to come to you for something like daily methadone. It's a huge barrier. So if you can decentralize it, get it out to clinics and pharmacies, that's the ideal. However, according to current federal law, that's not allowed for the daily dosing. However, there's a carve out saying that if someone's in acute withdrawal and is sick and wants to start, you can start them on methadone for up to 3 days in the hospital or health center setting. So if you embrace that and say, okay, we're going to do this, the key is you have to have a good relationship with your methadone program in your town, because ultimately that person needs to get transitioned within 3 days to that OTP. But it's a big improvement, right, to be able to start at any of the health centers, your methadone, or any of the hospitals, emergency departments, everywhere. Start onto methadone for 3 days and then get connected, rather than someone coming and being in withdrawal, wanting to start treatment to your health center, and you're saying federal laws tie my hands. My hands are tied. I can't start you on methadone, even though I know it's life-saving. So the 72-hour rule is a carve out, I think, meant to treat people, meant to prevent people who are sick from experiencing withdrawal symptoms, and we're taking advantage of it in a legal way, thankfully, to get people started onto methadone. And they've had a lot of success. They've started, well, I shouldn't say that. Let me back that up. They're in the process of rolling it out, but we have had a lot of success on the mobile unit and getting people started on methadone. Again, the model of being in a different place, not at the OTP, and saying, look, we actually can start you on methadone same day. And they have had a lot of success starting people that way.
Thank you. Other questions, comments? Linda? Oh, no, maybe not. Maybe you didn't have a hand up. Let me just make sure I didn't miss anything in the chat. Okay. All right. Well, Doctor, thank you. It's good to have you with us.
Thank you.
Thank you so much. All right. Our next presenter, Jessica Udon, serves as the Northeast Regional Manager at the Massachusetts Department of Public Health Bureau of Substance Addiction Service, what we all know as BSAS. And Jessica's been there for almost 10 years, and she's worked in substance use disorder field roles for 18 years. And at the state right now, her job includes the coordination and contract oversight for state and federally funded grants and projects and activities. And her unit is really the last resort for people who are struggling with substance use disorder and their access either to treatment or to wraparound services. So thank you for being here, Jessica.
Yeah, thank you for having me. And I wanted to say too, it's a great following up because we actually just released awards for bridge clinics for hospitals to kind of help support some of that work that was happening around the Healing Community Study, because I know that was mostly federal money from BMC. So we recently, I didn't include this as part of my presentation because I was just going to kind of do like a BSAS 101, but I did want to share that we did recently fund Lowell General Hospital, Lawrence General Hospital, Leahy, Beverly, Gloucester, Burlington, and Salem Hospital. So we'll be supporting their efforts in the bridge clinics. So when people come into the ER, setting them up with medication-assisted treatment. So yeah, all the programs look very different in every town. So that's a task that we are sorting through right now, but I did want to share that good news. So I do have a presentation. I know everyone on here may have a different knowledge base of BSAS and different ways of interacting with BSAS, whether it's prevention or treatment. So I did take out, like, it's not super detailed, but at the end I can also share a link that has like a self-paced training of literally everything BSAS does, if you are interested in more information. And I'm also happy to share or answer questions too at the end. Can you guys see this? I always hate when I share because then I can't see everyone. But yeah, can you guys see this?
We can't see it yet.
No. Okay, hold on.
There you go.
All right. Awesome. You guys can see this? Perfect. All right. So again, I'm Jessica Hunon. I'm the Northeast Regional Manager. My region is kind of the top little area of the state, which covers most of Middlesex County. Just for, whoops, there we go. So today I'm just going to briefly go over the history of BSAS, what we do, kind of our levels of care, BSAS structure, and then share some resources with you guys and hopefully answer some questions. So I am going to go kind of fast just for the sake of time, but I'm happy to answer questions, and I'll be at these meetings from now on too. So if things come up, feel free to ask. We get asked this a lot, like, why isn't BSAS under the Department of Mental Health? We used to be back in the 70s, and then we switched to be under the Department of Public Health. The benefit of that right now is actually that substance use services kind of get their own bucket of money, which is kind of nice. But yeah, I mean, that's always, we do get asked that a lot. And then in 2017, there was actually legislation that changed us to the Bureau of Substance Addiction Services rather than Substance Abuse Services. But the acronym stayed the same. It was still BSAS. So many people, I feel like, have heard of BSAS, but they're like, what do you guys actually do? So we fund a lot around prevention, intervention, treatment, and then also recovery services. And I'll go through kind of more details of what those look like. But we are the single state authority for Massachusetts. So we provide expertise and best practices for substance use services. We license any treatment facility. So whether or not they are funded by us, every substance use treatment service is funded through us. And then we also gather data and performance analytics from those treatment providers. And then we fund new initiatives and programs like the ones I just shared in terms of the bridge clinics. And then we also ensure access to treatment as a payer of last resort. So Mass Health does cover a lot of our treatment services. However, if an agency has a contract with us and someone shows up without insurance, they are able to bill BSAS if they have a contract. In addition, we also fund kind of new developments, like I said, the bridge clinic and recovery support centers and things like that that are not covered by Mass Health or insurance. So they're just looking at some data. In 2013, we served over 90,000 enrollments. Probably no surprise to you guys, but 44% of those, their primary substance was opioids. We are seeing a lot of polysubstance use, but in terms of data, we primarily do see opioids with another substance. And I wanted to note too, alcohol is not far off of that either. Like we do see, I think sometimes there's a big and rightfully so concentration and emphasis around opioid use treatment, but there's still a large percentage of people that are coming in solely for alcohol use disorder. This is one resource I wanted to make sure everybody knew about. I'll share the link at the end, but the BSAS helpline also has all of this information and how to get in touch with providers if you need that. So starting with prevention, the state funds over 200 municipalities. Some of you may be a part of some of that grant funding. These are the grants around that we fund prevention and municipalities through. Intervention, we fund SBIRT, which is screening, brief intervention, referral to treatment. That's primarily done through primary care, physicians, and hospitals. So if someone comes in, not necessarily for concerns around their substance use, they could be screened and then possibly receive treatment if screened in. And then also family intervention for families and parents of youth. In terms of the adult treatment center services, this is primarily what I oversee. And so our treatment level of cares are based off of the American Society of Addiction Medicine, which provides a framework for substance use treatment as well as criteria for knowing what level to place an individual. So we do provide ASAM trainings and resources to providers and to the community. So I can send you that information as well. In a nutshell, I know this slide is not ideal. I did not make these slides. They had to be approved. But in a nutshell, this is our levels of care in terms of treatment. So the ASAM level 4.0 is a medically managed inpatient withdrawal management. So if someone has medical complications in addition to needing withdrawal management, they would go to a 4.0 detox. And then the ASAM 3.7, or what we call ATS, acute treatment services, that's kind of your typical detox. So if somebody needs withdrawal management services, but there's no other medical complications, they would go there. An example of those in my region are the Tewksbury and Danvers ATS services. After that, somebody, if they are looking to further their treatment, may go to a CSS program, which is a clinically managed medium intensity residential service, or what we call a CSS, clinical stabilization service. So there, they might be there for 14 days and they're just being monitored by nursing staff, possibly receiving medication for either their substance use disorder, mental health needs. And then there's also too, under acute services, an option for outpatient detox as well as acupuncture detox, which I believe the only place doing that is Fenway Health, the acupuncture detox. Next, if someone decides to continue on treatment, they may go to a TSS, with transitional support services. This is actually the only level of care that isn't technically part of ASAM criteria. But here, somebody may be there for about 30 days. And the intention of this is, if you are there, you receive services similar to a residential program, while might be waiting to go and stabilizing to go to a residential program. A residential program is typically about 6 months, obviously based on clinical needs, necessity, and individual basis. But the typical stay is about 6 months. And we have co-occurring enhanced residentials as well. So if someone has mental health and substance use disorders, there are a few co-occurring enhanced programs in the region. Tower Hill and Lawrence is one of them, a men's program. And then they just opened a female program in North Reading, but I'm drawing a blank on the name of it. We also have adolescent residential programs, and then we also have adult programs with families. So there's a few in the state for male and females can go with their children. In the Northeast, we have Heart House, which is a female program. So a mother could go with her children to this residential program. It's located in Lowell. And then also fun fact about our state, our region, is we also have the operating under the influence second offender program. So there's only one in the state. It's at Tewksbury Hospital, but if somebody gets pulled over twice in a row for operating under the influence, there's a 14-day program that they would go to there. And then outpatient people are probably fairly familiar with standard outpatient services, whether it's group or individual, OBOT services, or OTP services, opioid treatment program services. Correctional facilities also have, some of them have their own medication assisted treatment that they provide, and then some of them contract with outside partners. So I know Middlesex, they partner with Habit to do methadone within their house of correction. So does anyone, I kind of wanted to stop here because I know this is so much information. I feel like people get really confused about sometimes the levels of care, and there's so many acronyms and things are called different things. Does anyone have questions about this slide? Because I know that is a lot. Yes. So.
As far as treatment in the rehabilitation centers, so do they get access to things like methadone while they're there?
Yes.
And it's so someone comes to the residence and just and gives it? So
wait, for corrections?
No, the rehabilitation.
Oh, yeah, the residentials. So they, depending on, it's an individual basis. So if the individual has ability to get take homes, which we strongly encourage, they're able to bring methadone back to the residential program, and the residential program the client will self-administer. So the program holds on under lock box, holds on to the methadone, and then the resident will self-administer the methadone every morning. Or if the individual is not at that space where they are eligible for take homes, they would commute to the methadone clinic every morning.
How do they get to the clinic if they have to commute?
It depends on the program and where they're at. Some programs will kind of like bus everybody to the clinic. Some programs, if it's close by, they can get a PT1 or Uber Health. Kind of depends on the situation and location of the program to the methadone clinic.
Thank you.
The residential programs are, they're set up to eventually support people to be independently living. So when someone first comes in, the program might drive them, and then by the end of their stay, they might be encouraging the person to be like, to start thinking about how are you gonna do this by yourself, and how are you gonna manage to get there. There are also a lot of programs are working programs, so an individual might be working or volunteering while they're there to kind of save up money for next steps and kind of gain those life skills that they may have not been gaining while they were actively using. I kind of already went over this, but just for acronym's sake, OBOT or OBAT, you might see them interchangeable, but office-based opioid treatment or office-based addiction treatment is Suboxone and Vivitrol. And then we also pay for kind of counseling and wraparound services around that for some of the OBAT programs. And then OTP is opioid treatment program, which is methadone. A lot of them now too are doing Suboxone, and then also counseling wraparound services. So you may also hear, like in general, that both of these being referred to MOUD or MAT, medication assisted treatment. So quick slide, and again, I can send these out or send a link with the self-paced training, but on the youth services, this is actively changing. Throughout the state, there's been a lot of changes around the youth system, but the youth system more or less mirrors the adult system. One thing that I think is really cool to highlight about the youth system is we do partner with DESE for the recovery high school. So there's, I think, 5 recovery high schools. The one in our region is in Beverly, which is a really great resources for young people in recovery. In terms of harm reduction, we do encourage harm reduction throughout the entire level of care, which is hard to show on a slide, but even in our programs, we definitely our treatment programs, we definitely still encourage harm reduction practices. And just knowing that the end goal of everyone is not to stop using all substances. So in terms of harm reduction services, we partner with the Office of HIV/AIDS and help fund syringe service programs, including, and they do work including outreach, mobile outreach, as well as most of them will have like a satellite spot for people with drop-in hours, HIV testing, viral hepatitis, STI testing, and then also linkages to care and treatment if they are interested in that, as well as Narcan. You can get Narcan for free at any of the syringe service programs. We call any program that's kind of providing free state Narcan and OE&D program, overdose education and naloxone distribution program. That's just some data on that and how much Narcan we've given out throughout the years. So, and then also our first responder naloxone grants too. So, I will say too, just kind of anecdotally, when I started at the Bureau, I oversaw this program, and the amount this has changed and the perception of Narcan has changed within communities and first responders has changed like dramatically over 10 years, which is great to see. And I think that's just attests to all the work that community partners like you guys have also been doing to help get the word out about Narcan. There's just been like a huge increase in Narcan distribution and just willingness to utilize Narcan and access Narcan, so, which was not the case even 10 years ago. So we also have a housing unit, and so for housing, we fund case management and wraparound services to agencies that offer housing. So we are not typically funding the actual housing. We are funding the case management and supports the staffing to support individuals who may have a substance use disorder that is in housing. So whether it's transitional, permanent, or low threshold housing, the contracts there. The other thing to note too, about sober housing, because I do think something in the community that does get confused sometimes is the difference between like our residential programs and sober housing. So our residential programs are treatment programs, or a sober house, BSAS doesn't oversee them. We partner with MASH, the Massachusetts Association for Sober Housing, and they will certify sober houses to make sure that they are operating as a sober house and not kind of the extremes of what we were seeing, whether it being really poor conditions, or we also saw sober houses that were offering treatment. And so the ones that were offering treatment, it was a way for MASH to be like, well, you either need to stop doing this or come in for our license. And then programs that were not operating well or not maintained well would also not necessarily get the certification. And part of this has then allowed people, one, to know that if it's MASH certified, they are going to a house that is hopefully managed and supporting their needs. But then also any state agency can only make referrals to sober houses that are certified by MASH. So in terms of recovery work, we fund the peer recovery support centers. There's quite a few in our region. The Lowell, I know a lot of you are from Lowell, so the Lowell Recovery Cafe. There's one opening up in Haverhill too shortly. Ray of Light, Lawrence, New Beginnings. Lynn just opened a recovery support center as well, and there's one in Gloucester. So there's quite a few recovery support centers throughout the state. We also do a lot of work with the recovery coaches in terms of training and licensing and whatnot. So this is kind of like where kind of some of our peer work and recovery coaches are. This is ever changing too. I feel like the work of recovery coaches has boomed within the past few years and has really been innovative in where we've seen recovery coaches and peer work happening. So. And then we also have a workforce development wing. As everyone can probably knows at this point that there's a huge workforce issue within substance use disorder. Well, probably in a lot of different fields. Yeah, I feel like a lot of our programs right now are very understaffed, which at the end of the day ultimately affects the people that are accessing our services. So we have been working very, very hard trying to get be creative and thinking outside the box about how we can support our workforce, whether it's through training, grants, also trying to support a more diverse workforce as well. So this is some of the work we've been doing around workforce. And then we also too, since you guys, some of you may work in this field, there is a website that we have called careersofsubstance.org. And there's always, like you can post job postings there or look for job postings there or scholarships, loan repayment information, and then also trainings and events. Another kind of resource that might be helpful for some of you is the Mass Clearinghouse. So there's services, there's information on here that you can access for free for your agency. So whether it's pamphlets, and the other thing I actually recently found out is free on here is why am I drawing a blank? Sorry. Fentanyl test strips you can order free on the Clearinghouse. Some other resources that I can share, again, I can share these slides. And then the other two resources, sorry, I'm just going to stop sharing for a second or share. The other two resources I really wanted to share with you guys are, let's see if this will work. So this, I'll send this link, but this is the link for the self-paced training, which goes into a lot more detail, and you can kind of take your time because I know I flew through that. But the other thing I wanted to show you, which I can't seem to show you. Oh, here we go. Is this website, which I don't know if you guys are familiar with, but it's the Mass Behavioral Health Access Line. And And I encourage people to use this in combination if they're looking for services in combination with their helpline. So if you are looking to place somebody in treatment services, you can actually click find provider opening under substance use and put in their age, zip code, and here, I'll just do it for. Oops. So say we are looking for a detox, so ATS, acute treatment services. And so these are all the programs within a 30-mile radius that have beds opening. And the programs are required to post their openings every so many hours, depending on the level of care and their turnover. And so right now at Danvers, there's 4 openings. And a comment. So Danvers ATS was closed for a little bit, and so they're not quite at capacity yet. They're slowly opening up their census to be at full capacity. But this is just a great resource, great resource if you're looking for treatment services for someone. And I can share that as well. I'm gonna stop sharing if I can figure out how to stop sharing. Here we go. There we go. Awesome. Does anyone have any questions? Sorry, I know that was super quick.
Jessica, people are wondering if you would share your slides. Is that something you'd be willing to do?
Yes, I can definitely share my slides. I did cut out a lot of slides for the sake of time, so I can send that link with the self-paced training that kind of goes into more detail, if that is helpful for people.
Questions, comments?
I'll also put my email in the chat, so feel free to reach out. I think there's no, I feel like there's no dumb questions. I get asked. Part of my job is like I'm the in between the community and in the state, and so I get calls with all sorts of questions, even if it's not kind of like government or funding related, even if it's just like treatment placement related. So yeah, I'll put my email in the chat.
That was a lot of great information. Thank you. Thank you. Thank you. All right. I see we have a question just to reference that statistic I gave earlier. And that was a study published. That was the statistic about almost 1 out of 2 people in Massachusetts are connected to someone who suffered a fatal overdose. That was a study by the RAND Corporation in the American Journal of Public Health.
I put an article in the chat that references the RAND study.
Oh, good. Thank you. All right. And now we are happy to have with us Samantha Ward. And Samantha is the Assistant Director of Reentry Services at Advocates, Inc., where she oversees the community support program from justice-involved programming and the behavioral health supports for justice-involved individuals who are in the Reentry Initiative. And these programs really help those reentering, obviously leaving jail or prison, to access services to address their substance misuse needs, their mental health needs, and really get people back on their feet. Many times, especially here in Middlesex, people have had pretty good services in the jail, and then they're released, and it's very difficult. We all know how hard it is to connect with services. And they're trying to do everything else, get a job, find a house, do all of those things, and get services at the same time. Samantha earned a Master of Science degree with a specialization in forensic psychology from Southern New Hampshire University in 2019. And she really enjoys helping those who were incarcerated or underserved in the community find their way back. So we are grateful for that, and I'm sure they are as well. And thank you for being here, Samantha.
Thank you so much. Good morning, everyone. I do have a presentation, so I'm going to share my screen and hopefully it works. Hopefully everyone can see this.
Yep,
Is everyone able? Okay, perfect. Thank you. So I work at Advocates. We have a lot of different programming at our company, which is great for lots of different people. So I oversee reentry and community care navigation services, which includes behavioral health supports and community supports, which is fairly new. It's been around for about, I'll say, a year and a half or so, and I'll kind of go over that. But our biggest program is the BHJI program, which is what mostly everyone is familiar with. So who are we? So we are a team. We work to help people get back into the community once they release from jail, the House of Correction, Department of Correction, even people who are just on probation or parole even. But we're trying to get them connected back into their community so that they can transition and have a productive lifestyle once they release into the community. So currently we have a team of 8 navigators and 1 clinical supervisor who oversees them. So that's who we are. We work closely, like I said, with Department of Correction, Houses of Correction, probation, parole, Mass Health, who is our funder, and UMass, who does a lot of our trainings. So our navigators are in the Houses of Correction and the Department of Correction weekly, and we have some navigators who are stationed at STAR programs in Lynn and Lawrence, and the community justice support centers also in those areas. So we currently we oversee Middlesex and Essex counties, and I'll kind of get into that a little bit more in just a bit, but that's who we work closely with. And then so our focus is connecting members to community providers, resources and supports. Kind of whatever they're looking for is what we're looking to help them with. So if they need intensive community-based case management, I mean, we're there to provide that and give them resources to where they can find whatever they need, access to different care and treatment, employment, housing, benefits. We're there to help them wherever they need to go. So for our program, for BHJI, there is eligibility criteria. So they have to be Mass Health eligible. They don't necessarily have to have it, as we will help them get Mass Health activated again if they need to. They have to be justice involved. So either active on probation or parole, detained or incarcerated within the last 12 months, or are going to be released from Department of Correction or House of Correction within 60 days. They also need to have a history of substance use disorder or mental health, or of course co-occurring, high risk for admission to inpatient, which is most of our members. If they're incarcerated, usually they're considered high risk. High risk for recidivism, which is again pretty common amongst our members. And they need to be either residing in or returning to Middlesex or Essex County. I will make a note that our program is completely voluntary, so we will never force anyone to enroll. I know sometimes probation mandates that they work with us, but we cannot force them. So we try to explain that to probation. But usually most of our members are super excited about the program and want to work with us regardless. So that's kind of a great thing about that. And then just a map so everyone can see. So we have been statewide for about 2 years now, I believe. And this is great because we had so many people wanting to enroll, and we just didn't have enough support for them. So now the whole state's covered, which is awesome. So these are all the different vendors that work in the different counties, and our website, there's a mass.gov website. You can go there and search for a town, and it will come up with who covers that town, and then the referral form for that if anyone needs to make a referral. But this is helpful, so I wanted to throw that in there. So our navigators are helping people, like I said, activating Mass Health benefits, accessing medical, behavioral health, importantly, substance use treatment providers. We are able to offer people who are releasing from incarceration gift cards for clothing and toiletries, cell phone with a 3-month plan. For people who are already in the community, we're still able to offer those. It's a little bit less, but just based on our funding from Mass Health. But cell phones are huge for us that we're able to offer, because obviously, as we all know, cell phones rule the world. So they need them to connect with primary care physicians, their probation officers, all of that. So that's something we're really excited that we can offer. We're able to pay for mass ID, birth certificates. We'll help them get social security cards. If they're in need of it, we'll help them with finding shelters, substance use programs, and applying for any other benefits. We do help with housing resources. There is a big misconception that we have housing. We do not have housing, unfortunately. That would be great if we did. As we know, housing is really hard to find. And especially for some of our members who have sex offenses, it's really difficult to find housing. So we'll do our best to find them housing, sober housing as well. We help with employment if it's referring to mass health or mass hire, mass rehab. Or, helping them fill out applications, we'll help them with that. Continuing education if they're looking for that, and vocational training, of course. We do help with transportation a little bit. We can offer cab rides. Sometimes our navigators will transport if needed, but we're really trying to help them get on their feet and be able to access transportation on their own, with a little assistance from us. So we'll also help with PT1 forms. We really connect them to the community, any peer recovery supports, and really anything they're looking to get help with, we'll give them the resources for it. There's really nothing we won't help with, if we can find a resource for it. So that's a majority of what we're able to offer. So I just wanted to touch quickly on CSPJI since it is kind of newer. So it's the exact same supports that we offer in BHJI. It's just dependent on their insurance. So if they have an ACO or MCO, they would be CSPJI eligible. Fee for service is now on the table for us, so that would also consider them to be CSPJI. But again, it's the same exact things we offer in BHJI. It's just for community and it's just insurance based. So just wanted to throw that in quickly. So our referrals, you can go onto our website, you can go onto the mass.gov website and download the referral. You can fax it or email. All of the referrals come to me, and I am trying to prioritize the best I can with, if they're incarcerated, their date of release. We are really trying to connect with people before they release, if possible. And especially with community referrals as well, we're just trying to prioritize like high needs, which can be a little difficult right now since we do have a little bit of a, a high referral wait list, but we are working hard to get it down. So that's just how to make a referral. So our team, again, 8 navigators. We have our program director, Jen Thompson, myself, clinical supervisor, and an intake coordinator, kind of helps with the behind the scenes things. So you might have met some of our navigators potentially, but that's our team. And I also want to throw in, we do have regional coordination meetings every other month. So if anyone is interested, please email me. We love to have more community referral providers so we can connect with them. And our next meeting is at the end of April. And again, it's every other month for about an hour. So if you're interested, we'd love to have you. But that is my presentation. I'm happy to take any questions. I know there's kind of a lot of information quickly. But yeah, I'm happy to take any questions.
Questions, comments?
Sam, can you talk a little bit about the time frame that you work with folks, and then some examples of maybe other programs that take over once their time with you has lapsed?
Yeah, so it really depends on the person. There are a lot of times where we lose contact, unfortunately. So in BHJI, when we start working with someone who's incarcerated, we could work with them anywhere from, the most common is anywhere from like 3 to 8 months or so. So we do have a short-term program. Usually we don't go over a year. And then we'll refer to, if they're, if some people are like, I just need a birth certificate, a job, and if that's it, then once they get that, they're kind of set on their way, and they can always contact us if they do need help in the future. But if they're looking for some longer term care, we'll connect them to whatever they're looking for. If it's like a residential program, we'll connect them with that. But yeah, it's kind of short term, and it really depends. It could, like I said, could be anywhere from like even 1 month. Sometimes people are good, to 8 months.
Thank you.
Anybody else? All right, Samantha, thank you so much.
Thank you.
Thank you. All right, I want to remind people that we have lots of Narcan, lots of fentanyl test strips, lots of xylazine test strips. So if people need that, just reach out to us. I am happy to get them to you. I'd much rather have people using them than having them sitting on a shelf. So please let us know that. Anybody have anything they want to publicize, anything that you're doing, anything you need? Programs you want to invite people to, anything? No?
Hi, this is Katrina Armstrong. I just wanted to say, sorry, I could only join the end of the meeting. Thank you so much, DA Ryan, for always sharing all of the test strips. The most important ones to us right now are those xylazine ones. I'm out at MassVac, and I would say 80% of the guys I see have lesions. So it's real. We've had a lot of really bad cases, and xylazine is everywhere. So please encourage your patients to use them. They work, they help us. And thank you so much, DA Ryan, for being able to give us that Narcan and those test strips.
Of course, happy to do that. All right. Well, thank you all for joining us. We will see everybody next month. And to people who put in the chat about being added to the list, we will add your email to our distribution list. Thank you all. Be safe. Take care.